Okay, so good morning, everyone, and thanks for inviting me. It's really a shame that I have not been able to join you in the nice country of Russia that most of you know that I like so much. And I would also like to thank my friend Igor Kornilov, who's always very kind to me to give this invitation for the RusECMO meeting. So first of all, I have to acknowledge that, as you can see here, I am affiliated with a new institution, which is a center, which is a branch of the University of Pittsburgh, which is located in the south of Italy, in Palermo. So what I will try to do in this short presentation is just to try to go through what has happened in the last months in the COVID-19 pandemic, and to take advantages of lessons that we have learned in order to approach and to program the second wave, which is actually coming here in Europe, in order to improve patients' outcome. Yet I want to reinforce that all data, despite the enthusiasm, report that in the first pandemic phase, mortality rates of patients who were in the ICU mechanically ventilated approached 70 to 80%. So these are very poor results. So the aim of the presentation is to go through some new concept that we have learned about the pulmonary and mostly the cardiac issues related to the COVID-19 infection, and therefore to plan optimized strategies to deploy extracorporeal support and cardiopulmonary support. From the background that patients who are admitted to the ICU because of severe forms of COVID-19 have a high range of comorbidities, and mostly referring to cardiovascular disease, because there is a high prevalence of hypertension, coronary artery disease, and congestive heart failure, and which is present in about 50% of patients who are admitted in the ICU for COVID-19. And these comorbidities drive a high mortality rate. Indeed, besides the issue of heart failure, we know that patients on top of the pre-existing disorder will develop some amount of myocardial damage, which is associated directly with the infection. And this is very important because myocardial injury, as evaluated with high sensitivity troponin, is associated with mortality. So any kind of patient who is admitted to the ICU and who has an amount of high sensitivity troponin release will face a higher mortality and morbidity. So this myocardial injury, indeed, it's a pleiotropic mechanism. So there are multiple factors which will promote the increase of high sensitivity troponin. For sure, we know that there is a direct damage to the myocardium, so myocarditis, which indeed we will discuss later. There are patients who will suffer from ischemic damage and will develop arrhythmias, heart failure, and cardiogenic shock. On top of that, we have to remind that severe acute pulmonary embolism, as a general rule, is accompanied by troponin release in the most severe forms, and pulmonary embolism is driving a significant amount of mortality in this patient's population. This is mostly related to the well-known features of the pathophysiology of the disease, which is mostly an endothelial damage, especially as much as the direct damage of the virus is related, and secondarily driven by the cytokine storm, which is more prominent in the more advanced forms. And again, I want to remember that inflammation and coagulation abnormalities, as shown by elevated values of interleukins, D-dimer, ferritin, and LDH, are markers of severity and are markers of the cytokine storm and procoagulant phase. In this regard, we do know that myocarditis has the most complex form of viral damage, because can be driven both by the direct disruption due to the viral contact with the myocardial cells through the ACE receptors, and the secondary phase has a prominent role in driving mortality. And you see here that the reported rate of death due to myocarditis with circulatory failure is about 7% in the COVID-19 population. And for those patients who were able to be evaluated by means of NMR, it is clear that there are peculiar features of myocardial damage at NMR. These features are quite wide in terms of imaging, because you can show abnormalities in the native NMR projections. In the you can see late gadolinium enhancement, which is myocardial but also pericardial. And now we are aware that also patients who have suffered from an asymptomatic form of COVID-19 will eventually show, if evaluated with NMR, features which are suggestive for myocarditis. Acute coronary syndrome is a further issue in this regard, because we know that the infection can drive disruption of coronary plaque and myocardial ischemia due to thrombosis. And on top of that, because of the epidemiological scenario that patients were facing at the very beginning of this pandemic, when especially in Italy, we were not ready to manage this wave, most patients presented with delayed forms of chest pain and ST elevation or non-ST elevation MI, which has driven a higher mortality and a higher prevalence of cardiogenic shock. Not to forget the fact that, as mentioned, the picture of heart failure can be dictated by not only acute myocardial injury, but also secondary features such as right heart failure due to pulmonary hypertension and arrhythmia, which is quite typical feature in COVID-19 infection. So at the end of the day, that when we are thinking of deploying mechanical support for COVID-19 patients, it's a matter of understanding this interaction between the lung and the heart, and having in mind that we need cardiopulmonary support. And some patients will show more prominent features of pulmonary failure. Some others will at first show more prominent features of cardiac failure, but some patients will develop a dynamic picture where pulmonary and heart failure will be continuously interacting. So I strongly recommend that all patients are systematically approached with echocardiography in the ICU, especially when they are requiring inotropic support, and any significant reduction of the left ventricular or right ventricular ejection fraction is evaluated for mechanical support, and systematic approach of the pulmonary artery catheters in deteriorating patients will be a useful tool for patients management. We know that ECMO, and as you have already shown in your Russian series, has been extensively used, but yet the data about ECMO are not reported fully. So we have scattered global data or single center data about the use of ECMOs, mostly by the EuroELSO report. And the Chinese have reported the use of ECMO, but the mortality rate is still high. And I do believe that especially in the first phase, when the pandemic was mostly challenging us in terms not only of clinical issues, but of resources, the use of ECMO at the very beginning was very restrictive. over the time when the structure was most able to manage the resources issue, then the access to ECMO was more easy and was deployed more frequently and has been deployed more frequently. Of course, there is no way to discuss that it is a percutaneous cannulation, and there is no role for surgical cannulation in this regard. And to be aware that cannulation is percutaneous, but the configuration of the cannulation is still a matter of debate. And I want to remind you that in order to provide successful ECMO support, we have to be aware that we can provide effective cardiopulmonary failure by means of hybrid strategies with concomitant VVA cannulation, double cannulation, pulmonary artery cannulation, so that we can now think of ECMO as a very complex strategy that with the technical features that have been available recently can provide extensive support also in patients who have combined cardiopulmonary failure. Of course, there is the role for the Impella device in this setting, because acute coronary syndromes have a more severe presentation. So we have patients who have a higher rate of cardiogenic shock. There are patients who have myocarditis, and we do know that this therapy is beneficial in this regard. But also the ECPella approach, which I'm very happy to support, has to be thoroughly discussed in this regard, because left ventricular venting is very important, because we do know that the reduction of right ventricular preload, which is provided by the ECMO circuit, does not unload the lungs. So pulmonary congestion is not reduced. Yet, when we have a VA ECMO support with a failing lung, we have a very high risk of Harlequin syndrome. And on top of that, if we put an LV vent in this regard, we might pump deoxygenated blood. So we have to unload the left ventricle in order to provide effective decongestion of the lungs. But at the same time, if we have combined cardiopulmonary syndrome, we have to be aware of the risk of pumping deoxygenated blood. The advantage of left ventricular unloading is definitely clear in the data for VA ECMO. And I want to remind you that there are two features which are nowadays very important. First of all, it's possible, and it's very important in the phase of resources restriction, to implant the device at bedside via echocardiographic support. And nowadays you can use the axillary artery approach, which allows, for instance, prone positioning, because the device is very stable if implanted via the axillary artery. Last but not least, when we are thinking of this cardiopulmonary support, we have to consider that the Impella can provide also right ventricular support with the Impella RP. And this mechanism of right ventricular involvement in the setting of COVID-19 is very important. And it has been shown that patients who have RV involvement as evaluated by alteration of longitudinal right ventricular strain have a worse prognosis. And the FDA has released the Impella RP for supporting right ventricular failure in patients with RV dysfunction in COVID-19. Another issue that I think it's very interesting in this regard is the issue of organ transplantation. Because at the same time during the pandemic that we were facing sick patients with COVID-19, there has been a significant reduction in the availability of solid organ transplantation, because organ donation declined, basically because the resources were reallocated and there were no options for doing ascertainment of brain death. And last but not least, because of the lockdown, there were no traffic accidents. So during that time, a number of issues have to be assessed in regard of organ allocation and transplantation strategies. And is an ethical issue because, of course, we had to manage seriously ill COVID-19 patients, but there were patients who were on the waiting list. And the criteria for urgency had to be changed because of the pandemic. And some corner stores should be revised because, of course, if you transplant in emergency a patient who is in the ICU, you will free some resources. You can use LVADs to provide support and to avoid these patients to get an organ who might be potentially infected with COVID-19. And the National Italian Center for Organ Transplantation has also released a paper which allowed the donation of COVID-19 positive donors to COVID-19 positive recipients. Another two last issues that I want to remind is that when we are treating COVID-19 patients with ECMO, we are using new drugs. So these patients are getting drugs that we did not use routinely in the ICU. So we have to rethink about the cardiovascular effects of these drugs, so which can promote cardiovascular depression and arrhythmias, but also the pharmacodynamics of these drugs on ECMO circuits, because there are very scant data in this regard. And the second issue is about the interaction between the inflammatory reaction of the patient and the ECMO circuit. So I think that there is a new approach to the inflammation and the cytokine storm via the use of steroids, immunoglobulins, or inhibitors of cytokines. And this might facilitate the biocompatibility of the ECMO therapy itself, because we are providing a therapy which is active not only on COVID-19, but also on the side effects of the ECMO circuit. And this is very attractive from the pathophysiological standpoint. We are also using blood purification techniques incorporated in the ECMO circuit, and this might similarly play a role also in blocking the mechanisms of COVID-19 disease. The coagulation profile is significantly altered, and the optimal anticoagulation strategy has to be discussed in this regard. I do believe that certainly these patients are prothrombotic. We do have to use more anticoagulants. We do know that heparin levels should be monitored via the use of anti-10A activity, because these other coagulation assays are surrogates which are affected by the disorder which is driven by the COVID-19 itself. And of course, I question whether these new direct thrombin inhibitors might be more effective in this scenario of ECMO patients with COVID-19 and prothrombotic state. That's it. Thank you very much.
Federico, thank you. Thank you very much for your lecture. It's very interesting. And I have one question for you. 10 or 20 minutes ago, we discussed about the patients who on VVA ECMO with COVID, but they developed, they begin heart failure. And what we have to do with them? Convert our VV to VVA or not? Because most of our speakers said that is not a good idea because chances is too small to survive. But what do you think? It's a good idea to convert VV to VVA, or use some, for example, Impella for patient with heart failure on VVA ECMO with COVID, or with septic shock on VVA ECMO with COVID.
So I think that first of all, we have to identify this heart failure very early. So we have to distinguish whether this is a primary heart failure which has been misdiagnosed, or it is a secondary heart failure, which is due to the fact that we are, let's say, not appropriately manipulating the patient's circulation. So in this regard, it's very important that we have monitoring, as mentioned, because if we can this running on the patient and decide with more facts. At the very beginning, everyone was very conservative with the use of pulmonary artery catheters, with echocardiography, because the concept was that we have to keep away from the patient. And in this regard, if you keep away from the patient, you will see only processes which are at the end of their story, so overt heart failure and cardiogenic shock. And then at that time, there is no option but VA. But if you can identify, and I think that now the resources are available to identify and monitor patients more thoroughly, this process will be different, and you will have the opportunity to avoid this sort of desperate therapies.
Oh, thank you. Some questions from the audience. Yes, one question from Daniel.
Federico, thank you very much for your presentation. The same question for different speakers and for you too. Do you see the difference between COVID patients on ECMO and patient on ECMO without COVID, any kind of pulmonary insufficiency? Thank you.
That's a good point. I think that these patients are different in terms of pulmonary mechanics, and these patients are different. At the beginning, because we implanted ECMO late. Now I think that we have learned that the best strategy would be, at least from my perspective, to accept low SpO2, but as long as this cannot be maintained, then go directly to ECMO without struggling with strange and rescue maneuvers.
Thank you.